So today's talk will be on approach to peripheral blood smear by Dr. Uma Manchanda ma'am. She's Director of Pathology, KEM Hospital, Pune. The session is chaired by Dr. Devdatta Basu sir. He's professor and of pathology in Puducherry, and Dr. Rajesh Kashyap. He's from SGPGI, Lucknow. The participants for today's are, I would request all the participants to address themselves. Dr. Suvigna, start by you.
Good evening, everyone. I am Dr. Suvigna, first year PG from Malareddy, Hyderabad.
Dr. Siddhi.
Good evening, everyone. I'm Dr. Siddhi Pawar, third year PG from BJMC Pune.
Dr. Shibu.
Good evening, everyone. Myself, Dr. Shibu Krishnan. I am second year PG from RCC Trivandrum.
Dr. Rajendra.
Good evening. I am Dr. Rajendra Prasad, sir, second year resident, Jipmer, New Delhi.
Dr. Wrinkle.
Good evening, everyone. I'm Dr. Wrinkle Patel, third year PG from Smith.
Dr. Namrata.
Good evening, everyone. Myself Namrata, second year PG from VDGMC Latur.
Dr. Nisha. Dr. Pratik.
Good evening, everyone. Myself Dr. Pratik Deshmukh, third year postgraduate from KMCRI Hubli.
Dr. Sujit. Welcome all the students. The session of today is today's session is moderated by Dr. Hina. Sorry, yes, sir.
There's a background noise. Somebody's, please tell your background. Somebody shouting in the background. One of the students.
Who's Anup?
News. Still the news are on. Somebody's watching news on the. Please mute it. Thank you. Yes, Shilekha, continue.
Sorry for the glitch, guys. So today's session moderators are myself, Dr. Srilekha, and Dr. Hina, who is an assistant professor from Latur. The webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. A gentle reminders to all the students, if there is any interruption, there is low sound or no sound, or if there is video freezing or video lag, kindly leave the meeting and rejoin the same with the same link. If there are problems still persistent, please check your internet connection. Answer the poll questions in the chat box itself, and do not send any requests for annotations to the presenters. These are few disclaimers.
Can't hear.
The upcoming talks are on good cytology preparation, which is on 10th of July, 2 days from today. And next Tuesday, it is approach on exfoliative cytology by Dr. Nalini Gupta ma'am. So we'll go ahead with the session for today. Over to you, ma'am.
1 minute. Yeah, my camera is somehow, you can't see me, I think.
Yes, ma'am. We can hear you, we can't see you, ma'am.
Yeah, it's okay, madam.
Okay, ma'am. Please carry on.
Yeah.
We can hear you clearly.
Very good then. I will...
But can you see your camera, madam? Can you see your...
I don't know, something suddenly has happened to...
At the start video. There is still somebody watching news at the background.
Yeah, I know.
Yeah.
I think I'll have to check. I am not watching any news.
No, there are, I mean, what about all the other people who have joined right now? Maybe one of them. I see a whole lot of people in this group.
Abhi band hua hai.
Abhi band hua hai, yes.
Please be careful. I asked madam. Ma'am, it's okay, ma'am. You will.
Can you?
Yeah.
Can you see my slide?
Yeah.
Yes.
No, but you can't see me. Oh, really?
We can't see you, madam. It's okay, ma'am. I think now we'll have to.
It's okay. It's all right. It's okay. All right. Okay. Good evening.
Dr. Gujral, thank you so much for including me in this very, very interesting and very needed activity for all of us as well as the students. Dr. Basu and Dr. Kashyap, thank you for being there to be
Welcome,
there.
ma'am.
I will be talking. Students, welcome to all of you. And I'm going to talk on a very simple investigation, which is the peripheral blood smear. Believe me, it is one of the most important investigations. And I love talking about it because it is like a detective work, like a Sherlock Holmes. And you have to put pieces together to come to the diagnosis of this. Quickly, coming to the peripheral smear, first of all, it confirms all your blood counts. It confirms all your readings that you get, and that is very important. You have to first confirm what you are seeing is what is being given as the counter is giving. You must recognize what is normal. I have put it in capital letters because what is normal, you must know, because it varies. It varies from neonates to babies to women, men, age-wise. So you must know who is your patient and at what age the patient is there. What you see, you recognize. You recognize what is the pattern. What are you seeing? And then you use the information which is already in your brain, that the pattern that you recognize, what is the information that it is giving it to you, and then do the clinical correlation. Absolutely important, because if you know who is your patient, you can give much more information to the clinicians also. So little bit of data from the clinical side about age and at least what is the problem that they're looking at. Is it anemia, bleeding disorder, PUO, or is it just general weakness? Must know what is happening and why are they requesting this CBC. It is putting all this together, and this is what gives us the direction which way to proceed for the problem in that patient. It is very important because hematology is a vast subject and you have so many tests and different directions, but which way to proceed for your patient, you have to really find, and peripheral smear is the one which gives you the directions. I always look at blood. I don't look at it as a single cell. I look at it as an organ, like you would look at the lymph node. You will look at the lymph node at the cellular level and the way it is organized. You look at the capsule, the nodules, the cortex, and the medulla. So that way, I think you should look at your blood also. It may not be looking like an organ, but it is an organ. You must know the cells in it. Is the number normal? Is it absolutely increase or decrease? And if the cells are there, are they normal cells or abnormal cells? You must know what is normal to recognize the abnormal. And one more important thing, the relationship. As in humans, relationships amongst these cells is also very, very important, because that is where they tell us about the disease process that these cells are encountering. And don't forget, these cells are hanging in plasma, and you must know some of the abnormalities of the plasma will affect these cells as well. A good smear, we all know, must have a head, body, and a tail. And the zone which you must look at is the one which is the zone of morphology, as I'm showing here. And this is the area where you will get the best morphology as well as your differential. This is the way how I do it always. Full 100 cell differential No shortcut to good work. Please remember, this is the zone of morphology, and don't come towards the tail end also, because the tail end might give you certain problems. Here is the tailing artifact. Now, if this cell or properly, if this slide has been made, which is a very thin slide, looks very beautiful, but it has drawn all the big cells towards the tail of the smear. What is the differential you are going to get in this area? It is absolutely wrong, because this is giving a poor distribution to the leukocytes. It is very important the smear has to be made in a way that you have a body, the head, body, and the tail. Don't make tail only or head only. And this spreader has to be at 45 degrees angle to give you a good drawing smear. Some of the changes that we make, if you are collecting in EDTA, which all of us collect for CBC, I prefer the first drop to come onto the slide to give me the fresh look of all the cells that I'm seeing. But many times it's not possible. So you have to resort EDTA smears. Please remember, these EDTA smears can carry artifacts, and I'm showing you some of them. But please make your smears within the first hour after collection in the EDTA. This is a neutrophil, looks like a neutrophil, but look at the lobes. It's almost karyorectic. The nucleus is breaking up like it is happening here. This is a mononuclear cell. You don't know whether it's a lymphocyte or a monocyte. Look at the petaling artifact that is seen. This has also been created by an anticoagulant smear. Neutrophils may lose their lobes. They may look like this. What are you going to interpret this as? It's not a myelocyte, but it's a cell which has been altered due to the anticoagulant effect. The red cells will show you acanthocytosis, pycnocytosis, whole lot of changes. Please make your smears and insist on a good quality smear, well stained and made in the first hour after collection. Absolutely necessary if you really want to give importance to this very small but very important investigation. Coming to the normal blood smear, it should be beautifully seen like this one. You have a very well stained smear. It is very well distributed in an area where there is little overlapping of the RBCs. Some of the cells should be lying singly scattered. Some will be overlapping. And this is the area which is best for morphology as well as for your differential. You can make out that the platelets are showing you little clumps, and that is the indicator that this has been made from a fresh, I don't mean fresh EDTA. The moment the blood touches the EDTA, the platelets scatter. You will not get a small, tiny clumps like this. When we are looking at the peripheral smear, we are mainly concentrating on red cells, white cells, and platelets for different reasons. Red cells mainly for anemias or red cell disorders, white cells for infections, PUOs, and platelets mainly for the bleeding. Coming to the red cells, they are very beautiful. They look lovely if they are taken care of and you interpret it properly on the smear. These red cells, you must look at the size. What is the size? You must compare with the small lymphocyte. Small lymphocyte, which is about 7 microns in size, gives you the indicator. We know RBCs are also 7.5 microns. So if your RBCs, all of them are looking like the size of a small lymphocytes, you have a normal size. Compare it, and then you have to interpret whether the size is larger, a macrocyte, or the size is smaller. And the shape, is it nice and round with a very sharp outlines, or is it having crenated edges, or is it not round and showing you different shapes, which is called poikilocytosis. These poikilocytosis are giving us some messages about why they have become poikilocytes, what has altered their shape. So look at the shape of your RBC. Next comes the hemoglobinization. We know that 1/3 of the RBC in the central area usually has a pallor, and that pallor is normal because it's a biconcave RBC with a dip in the middle of the RBC where you don't see the hemoglobin molecule, which is seen at the periphery of the red cells. We will come to this a little later. Are there any immature RBCs? What do I mean by immature? Precursor forms like late normoblast, intermediate normoblast, which are not supposed to be in the peripheral blood. But if you see them, you have to look at them. Why are they present? And the interpretation will depend according to what you are seeing and why are you seeing them. The red cells sometimes carry certain inclusions. We'll be coming to these as I go along in my talk. These inclusions are also giving you some signals. These inclusions are telling us that there is some dyserythropoiesis happening in the body. And we will come to the interpretation of all these inclusion bodies. And as I said, the relationships. How are they arranged amongst themselves? I've shown you one slide which shows only few RBCs overlapping. The rest are lying singly scattered. But if the arrangement is in a different way, we will make it, we'll just discuss that to show you how this arrangement of cells also changes the interpretation and can lead you to the diagnosis of the rarest of the rare problems. So the arrangement you must look for. We know that classification of anemias from the laboratory side, it is morphologic classification. We look at the morphology and try to look at the etiology or decipher what could be the etiology in that particular patient by looking at the morphology. So we are going by morphological classification of anemias when you're looking at the peripheral smear. As I said, the size is the one which decides. Can be microcytic, normocytic, or macrocytic, depending on the size. Is it normal size, smaller size, or larger than normal RBCs? We are very familiar that certain group of disorders can cause microcytic anemias. Normocytic normochromic anemias are seen in usually bone marrow problems. Some pathology in the bone, in the marrow, in the production of the RBCs normally gives rise to normocytic normochromic anemias. Coming to macrocytes, larger cells, these are the ones which are usually seen in many conditions when we go along, but the commonest are liver disease and certain deficiencies like folic acid and B12 deficiencies. So our morphological classification first, when we have looked at the red cells, we have some idea which way we are going to investigate our patient further. Let's look at one case. This is for you people, and I want some inputs on this. It's a 45-year-old female. Weakness, pallor, lethargy, look at the parameters. Hemoglobin, low, 8.2 grams. Hematocrit is obviously low. RBC is 4.9 per cubic millimeter. MCV 59 and RDW is 18. That is the blood picture for you. What will you think of? First thing, when you look at the smear like this, can somebody answer this, please? Anybody? Anyone? Can you hear me?
Yes.
Anyone?
Anyone?
Just unmute and answer. Who, Pratik, you're answering.
What do you
Okay, go ahead.
see?
Pratik, go ahead.
Go ahead, go ahead. No? Nobody coming forward? What do you
Pratish,
think?
you was
Yeah,
Ma'am,
come on.
I think of microcytosis.
Very good. Yes, because look at the MCV. Look at the size of the RBCs. So these are microcytes. Agreed. So it's a microcytic anemia. And it is also hypochromic.
Yes, ma'am.
Yes? Yes. It is hypochromic. So it's a microcytic hypochromic anemia. Next, you must look at is the RDW. What is the distribution of these RBCs? Are they variable in size or are they fitting all microcytic but some larger, some smaller? So you must look at your RDW when you're looking at microcytic hypochromic anemia.
Ma'am, just 1 second. I think some of our students have got muted. Dr. Srilekha
Okay.
or
Sri
Ruchi,
Lekha?
would you just take care of that? They are unable to unmute themselves.
Yes,
Oh,
sir.
I
Yes,
see.
sir.
Ruchi.
Requesting all students to be unmuted itself.
Yeah.
Unless and until there is a background sound, keep yourself unmuted as of now.
They are unable to unmute, I think.
Dr. Basu, you can hear me clearly?
I can hear you clearly. I hope you can all hear me clearly. We can hear you, ma'am, but I think these people are not able to answer your questions.
I unmute one by one, sir. Students.
Yeah, I think
Yeah,
Shibu
do
has a
that.
lock
Do
in front of Shibu, Siddhi, all of them have a lock in front of their mic.
Please
Yeah.
unmute yourselves.
Shibu is all right now.
Yes,
Shibu, check.
yes, it's all right.
Yeah, Siddhi, you are, I think. And please keep yourself unmuted, all of you.
Okay, sir. Thank you, sir. I'm unmuted now.
Yeah.
Okay, so the question was, you have a microcytic hypochromic anemia with RDW, and RDW tells you how much is the anisocytosis, how much is the variation in the size of these microcytes. Some are very small, some are small, but not all that small. Then there are some polychromatic cells, which are larger, and that tells you that RDW is usually high. Now, when you have a microcytic hypochromic anemia like this, you will start thinking of all the conditions that are seen due to iron deficiency. Please remember that microcytic anemia can be due to iron deficiency as well as normal iron stores. How to differentiate between these? Looking at the peripheral smear. If you see an isochromia, like you see here, some are very hypochromic, some are normochromic, and the others are fully hemoglobinized. When you see an anisochromia like this, you are looking at the first category of microcytosis, which is iron deficiency. In this particular case, it is usually proper iron deficiency can be due to increased requirement, can be due to impaired absorption, or chronic iron deficiency, or any reason bleeding anything where the person is losing blood in the urine or the stool. And that is anisochromia is one of the important observations on a peripheral smear, which tells you, please think of iron deficiency before you think of the other group of disorders, which is, hello?
Yes, ma'am. Continue. We are hearing you.
Okay. All right. So the normal iron store group of disorders, which is also microcytic hypochromic, like thalassemias, they are all hypochromic. Anisochromia is not a feature of thalassemia trait. Even other disorders may not show you so much of anisochromia as pure iron deficiency. So a microcytic hypochromic can be due to any of these conditions, and you know which way to proceed when you are going to investigate your patient. Here is one indication that you can see a stippled red cell, basophilic stippling, mostly or almost never seen in pure iron deficiency. It is seen in thalassemia traits, which is a very important feature. And that is another added feature if you have a microcytic hypochromic anemia with stippling. It is likely to be a thalassemia trait. Will not have anisochromia as well. One little catch is there. A smear made from EDTA sample may not show you the basophilic stippling. This is something which is we are making in the lab from a fresh smear, which is altered ribosomal, this basophilic stippling, which is dyserythropoiesis. But in EDTA, somehow these stippled red cells are not standing out very well. So best is if you have a fresh smear, you can diagnose beta thal trait right looking at a microhypo with target cells and stippled red cells. Most likely you will not be wrong. Basophilic stippling, if it is seen in microcytic cells, as I said, it is pointing towards thalassemia trait. If it is seen in normocytic cells, you can think of lead poisoning. And if it is seen in between, then sideroblastic anemia is another condition. But if you see in macrocytic anemias, megaloblastic anemia shows you beautiful basophilic stippling, which is seen on the peripheral smears. What are the investigations that we will do in this particular case? Look for retic count. I'm giving you certain readings. Iron TIBC and percent saturation. So serum transferrin saturation, ferritin, electrophoresis, fetal hemoglobin, and giving you HbA2 estimation. Can somebody answer now that this particular microcytic hypochromic anemia is due to what reason? Can somebody
Siddhi, please
decipher
say.
this?
Or Suvinya, please tell.
What do you think of retic count? I put it in red. I should not have actually. I should have just put it in black as well.
Normal should be 0.5 to 2.5, ma'am.
Okay, yeah, 0.2 to 2 or
Slightly
2.5.
raised.
So it is raised. Retic is raised. What about transferrin saturation?
It's normal, ma'am. Ferritin
Normal.
Yeah, normal. Yeah.
Ferritin normal. And electrophoresis is showing you normal AA
normal.
pattern. Yeah?
Looks like
What about A2?
What about A2?
HbA2? Will somebody answer?
Ma'am, it is increased.
So what is the normal range?
3.5 to 4.5.
No, less than
Probably
3.5.
1.5,
Up to
1.6
Up
to
to 3.5, please.
3.5.
Up to 3.5, yeah.
Up to 3.5. And here, this patient has 5.5. So what is your interpretation now? You have a hypochromic anemia. And you have these readings in front of you. What will you think of?
Yeah, Wrinkle, what are you thinking of?
It seems like thalassemia.
Beta thalassemia trait.
Yeah,
Beta thalassemia trait. Very good. Yes. Beta thal trait. Now my next question is HbA2. How high can it go in beta thal trait? Anyone?
Anyone? Shibu or anyone?
Okay.
Yeah, on the chat, they are saying 6. On the chat, many people, ma'am, are answering, responding as 6.
Saying 6 is no, yes. 6 is correct. My question is,
How high?
how high will it go? Above that, you will not think of
Beta thal
beta
trait.
thal trait. Now, suppose I say it is 10.2. A2 is high and it is 10.2. Will you still think of beta thal trait? No, you will not think of beta thal trait above 10%. The reason being, when we are taking sometimes a class with you people for hemoglobinopathies and HPLC, the A2 is alpha 2 and delta 2. If you remember, delta chains cannot be produced more than 10%. So please just remember that if you have an A2 estimation of 10, 15 or 25, it cannot be beta thal trait because delta chains are not produced more than 10%. That is why you must look at some other variant which is eluting in the A2 position. Am I clear? Anybody wants to ask?
Which is the variant? Which is the hemoglobin that elutes along with A2? Suppose you have a case of 20% A2. What is your thought?
Yeah.
Which hemoglobinopathy?
Which hemoglobin will elute an A2 20-25% A2? Anybody?
HB.
HB?
E.
Yes?
E. Yes,
Very
E.
good.
Or
Absolutely
even
right.
Lepore. Lepore is
Lepore,
about 20.
between 10
Beyond
and
that
20.
is HBE.
Yes. 10 and 20 can be Lepore. 20, 25 and above HBE, heterozygous. Okay? Okay, all right. Very good. Thank you for your interaction.
Dr.
I
Manchanda?
have a mail.
Ma'am, there's one
There is
little
a question by Sarah. She's asking
Yes.
why HbF is 0%.
HbF, depending on the methodology that you are using, sometimes the F, the gamma chains may not be seen. And this was an electrophoresis. As I've said, have
May
a
not
look at
pick up.
this. May not pick up. If it was HPLC, it would have picked up. Am I clear? It will not be increased, but it will be less than 1%. Normal adult fetal hemoglobin is usually less than 1%.
Rajesh,
Is that
any
clear?
comments from you?
Yeah.
Rajesh, any
Ma'am,
comments?
there's
Yeah,
one more point I'd like to.
Yeah.
Dr. Rajesh, please go ahead.
Rajesh.
What I also wanted to stress upon a point, ma'am, would you please show the slide on the investigation?
Yes, please.
So suppose if I were to say that the serum ferritin is around 15 microgram percent. So what
Sure.
would the students say? A2 is
Yeah, students.
5.5 and 15%, 15 micrograms.
Yeah, ferritin is 15 microgram percent and A2 is 5.5. What will the students think of?
Yes, combination of IDA and Thaltrate.
So
Mandeep has said
Yeah,
in the chat.
IDA and PAL.
So
No,
you
Because
I have a point on that, Dr. Rajesh and Dr. Ruma. If it is a association of iron deficiency with Thaltrate, A2 will not be so high.
yes,
One of the causes
yeah,
of
it
low
will
A2
not
is
be high,
low A2
but
is
it will still
IDA when
be
low.
above 4.54%.
yes,
Yes,
it will be
it will
above
not go to,
3.5.
yeah,
It
that's
can be.
right.
So as a clinician, I'll just tell you how when we do this. As the first slide, ma'am said, peripheral smear is a Sherlock Holmes in hematology pathology.
Yes,
So
yes.
you cannot leave any clue. Now the emphasis is always when you see a peripheral smear, always look at the clinical profile. So here we have a 42-year-old female, and iron deficiencies are quite common. Now, why I give this scenario is like,
Yes.
suppose if you are working in North India, you are working in Punjab, Delhi, you will invariably see a high proportion of thalassemia trait. Now, because they are in the third or fourth decade of life, iron deficiency is quite common. So you will always get a concomitant. So we always, as lab side, we will always make the error and look at only the one aspect and say that it is thalassemia trait. And then we sign out. The clinician will go ahead and forget that there can be a concomitant iron deficiency. The same scenario will change. So now if you get it in a pediatric age group, instead of 42-year-old female, will make it, suppose if it is a 10-year-old female, then the issues will become different. Because then, and suppose if the patient is on a rural background, and madam has said that there are basophilic stippling, what will the resident think of the diagnosis? A 10-year-old female patient coming from a rural area and gets an iron deficiency like picture, but there is a lot of quite significant basophilic stippling. A2 is normal, less than 3.5, so thalassemia trait is out. Lead poisoning to be seriously thought of.
You will think of lead.
Okay, so it's quite common. The reason is because you use the paints on the wall. Nowadays we have lead free, but it is the commonest causes, especially in young children, is that they have pica, so they will be scratching the walls and eating. So we
They
quite
even
frequently.
eat pencils.
Yes, pencils, lead pencils. So so now we have a lead. So it's you have to remember that it is the person who is saying the peripheral smear would actually be guiding the clinician to pick up the right diagnosis. So
that's right.
So you, as madam said, look from the head to the toe. So the or the tail of the peripheral smear. So that's very important. Not even a single finding should be missed out. Yes. So I think.
Thank you, Dr. Rajesh. Thank you so much.
One more point,
Yes.
Ruma. Right in the
Yes,
beginning,
please.
the RBC count of 4.94 was a bit unusual for pure iron deficiency anemia.
Absolutely right.
45-year female. So that was where I think someone in the chat mentioned that Menzer is coming as low, which is true. I mean, always keep it in mind. An MCV of about 54, RBC count high enough, 4.94, may not have crossed 5 million. Keep a point that this could be an associated iron deficiency with a thaltrate. That's pretty common, especially in the northern part of the country.
Absolutely. Absolutely right.
These are all the clues that you pick up while you are looking at a case.
Very true.
Okay.
Absolutely right. Okay. Shall we move? Any questions, any queries? Very good suggestions.
I had one query, ma'am. I had one query.
Yes.
Ma'am, you had mentioned
Yes.
hepcidin adenoma. How common is it, ma'am?
Yes.
I mean, I have not. It's common.
It
I
is
have not
very
encountered
common.
so far.
It's not very common, but it has to be kept in mind. And we've seen 2 cases of this. And that is why we should not miss it. Very important. Keep it in mind. Get an ultrasound done. in an unresolved, if you can't find any reason for the iron deficiency,
for iron
please get an
deficiency.
ultrasound done for liver.
All right. That's a good
Okay.
point.
Yes. Now, I'm putting a case. This was another case which I saw. This boy was 18-year-old, short-statured, delayed puberty. This is a case which taught us that we have to look at different reasons. Like you said, hepcidin. Here is another one. This boy looked 20. He looked like 7-year-old boy. He was very well suited with a little belt and a shirt and a pant, but he looked like a little man, 7-year-old. Look at the weight and look at his height. He had had 4 to 5 transfusions in the past. And the first was at the age of 5 years. Please note this. 5 years, first transfusion. Received multiple courses of supplements and iron. He was very pale. No icterus, no hepatosplenomegaly. Look at the readings. He was severely anemic. Low RBC, MCV low, WBC normal, neutrophils were mildly low for a 17-year-old, but remember he had not grown for puberty. His differential still remains like a child. His retic was 2%, platelets were normal, little on the higher side. Look at the ferritin. So we did the occult blood, looked at GI tract survey, found giardia, but couldn't explain such low HB on this parasite. We could see that the RBC graph had shifted to the left, the histogram. So we did treat, upper GI scopy done, nothing found, ordered a TTG test, IgA, and this boy turned out to be celiac disease. Why I'm bringing this case in front of everybody? Because don't miss celiac disease in Indian subcontinent. We have lots of them. Imagine at the age of 5 years, if somebody had diagnosed him as celiac disease, poor boy would have been a strappingly tall, handsome 17-year-old boy. He had stunted growth because he's chronically anemic, not absorbing because of celiac disease. So not to miss cases of celiac disease in our population. If you have a child, especially for pediatricians, and in lab, if you get a child again and again with low HB not responding to iron therapies, please order a serum tissue transglutaminase test, IgA, and not to miss celiac disease. I felt very bad for this boy. So my request is, keep everything in mind. It may not be very common, but if you miss some of these, you will land up with somebody who is for life stunted and cannot grow now at the age of 17, 18. So that is my algorithm for microcytic hypochromic anemia. The blood film guides you, the peripheral smear guides you. Ask for serum iron TIBC. You must do the iron profile, whether you are suspecting THAL or not, but definitely do the iron profile. If it turns out to be high, look for marrow iron. You might be dealing with sideroblastic anemia. And it may be THAL or hemoglobinopathies. But if it is low, look at your bone marrow iron. If the bone marrow iron is high, that means ferritin storage iron is high, you are looking at a patient of anemia of chronic disorder, but pure iron deficiency will also have low ferritin. So that is my usual approach. And I request everybody to please think of this. The important thing is that in all microcytic hypochromic anemias, please get an iron status done. Iron, TIBC, and ferritin. Not only ferritin and not only serum iron and TIBC and percent saturation. I hope that point is clear. Any questions on this? Okay. Coming to the next category, which is normocytic normochromic anemia. That's the blood picture. Very nicely hemoglobinized, little bit of variation in the size, anisocytosis is there. Hemoglobin looks normal. The reasons are, as I said, if you have a normocytic normochromic anemia, think of a bone marrow problem first. Aplastic anemia, anemia of chronic disorder, renal disease, hepatic pathology, even acute blood loss, where the bone marrow has had no time to respond by throwing out retics and anisocytosis. A fresh acute blood loss will also have normocytic normochromic anemia because there has been red cell loss and the production has not compensated for it. Leukemias, as I said, bone marrow problem and myelodysplastic syndromes. These are, so basically think of a marrow problem whenever you're looking at a normocytic normochromic anemia. Here is a gentleman. I want you people to look at this case. 68-year-old man, he had pain in the abdomen, difficulty in walking, pallor, and he was admitted in ICU in an unconscious state. The history was given by the wife that last few days he was having very great difficulty in walking. He was standing, talking on the phone, and suddenly collapsed. His hemoglobin was 9, MCV 89, normal WBC and platelets. Any thoughts? That was the blood picture. Anybody? What do you see?
Shibu, why don't you try now?
Lot of basophilic stippling is there.
Yes. Now, as I said, basophilic stippling, if you see in microcytic cells, you will think of hypochromic microcytic anemia. But this gentleman is normocytic normochromic. Coarse basophilic stippling.
Sideroblastic anemia, ma'am?
Sideroblastic, yes, can be sideroblastic anemia. Look at the clinical
How do you account
history.
for his, yeah.
Myelodysplastic syndrome.
Yes.
The important thing is that this gentleman had GI tract problems, pain abdomen, difficulty in walking, and unconscious. This gentleman was highly diabetic and earlier he didn't tell us. He had a foundry. But he said when he came out of his unconsciousness and he was alert and he was treated, we asked him that what was his profession. He said, I have a foundry, but my sons look after the foundry. I go and sit in the office and I don't go into the foundry. Then we said, then what? But he was diabetic. So we said, do you take any alternative medicine? He said, yeah. मैं अपना दवाई तो बंद किया, बहुत टाइम हो गया, अभी तो मैं यही खा रहा हूं, ये गोलियां हैं, which have been, that was lead poisoning. Please understand, there are anti-diabetic tablets being taken up by the diabetics, and we all have to be aware of this, that we are not taking history from our patients about the indigenous medication that they keep popping up, thinking there is no side effect of these. This gentleman had proper lead poisoning. His serum lead levels was 50 times the normal level. and he was treated with BAL, and he came out of everything, walked into the clinic again, and of course, he stopped taking these tablets which were available from a off-the-counter Ayurvedic preparation. Please take the history. Keep it in mind. In India, we have a lot of people popping up these thinking they don't have any side effects. Lead poisoning is the one which is a very important cause of lot of morbidity. इतनी पेट में उसको दर्द थी that he could not eat, he was becoming anemic, he could not, muscle weakness, and of course, treated, he was absolutely okay. So my request, keep in mind the basophilic stippling, you may not see in an EDTA smear, but if it is very coarse, you may see it if you are lucky. In a normocytic normochromic anemia, that is my approach. And here, the retic count is your center of attraction. Retic count. In a normocytic normochromic anemia, as I said, it is the bone marrow. You are looking at a problem in the bone marrow. And if the retic is high, please look for blood loss hemolysis chronic. Otherwise, there are a whole lot of conditions which are the ones which are causing this normocytic normochromic anemia. Do a bone marrow. If it is normal, you're looking at secondary anemia of chronic disorder. If abnormal, then what is the abnormality? It may be aplastic, leukemic infiltration, metastasis, or myelofibrosis, and can be dyserythropoietic and myelodysplastic syndrome, like one of you said. So please, that is the approach we do for a patient of normocytic normochromic anemia, and the retic count is the center point which decides which way we should go further in which group of patients. Here is another case. 11 years female, easy fatigability. Pallor, has jaundice. On examination, very pale, mild icterus, mild hepatosplenomegaly. Look at the investigations, please. HB, WBC, PCV, MCV, MCH, MCHC, RDW, and that's the picture. What does it show you?
Hypersegmented.
Hypersegmented neutropenia.
Yes, and
macrocytes.
Macro-ovallocytes. Macro-ovallo, right? And this RDW is because of the microcytes, smaller cells, fragmented cells, and macrocytes. So it is telling us a lot of anisopoikilocytosis is there. This was the case, and that was, what is this that you see here? Is it seen clearly?
Polychromatophil.
Polychromatophil and Caboring. Very good. This is the feature of dyserythropoiesis that we see in sometimes this type of anemia. This patient had retic of 4.5, platelets, bilirubin, mildly jaundice. Can somebody tell me, why is this patient jaundiced?
Raised RBC destruction.
RBC?
Destruction. Raised.
Yes, you're right. Absolutely
Raised
right.
RBC destruction.
Where?
In spleen.
In spleen, okay. Anybody
Where
else?
is the RBC getting destroyed? Anyone? Yeah, someone of you writing that ineffective erythropoiesis. What does that mean?
Writing, sorry?
In the chat, people are saying about ineffective erythropoiesis in the bone marrow.
Yes, ineffective erythropoiesis. That is where it is called intramedullary death. The cells are not maturing further because of the deficiency of B12 and folic acid. So we will do further test. What will you do? In a typical case like this, B12 folate estimation should be done. Look at the reasons for macrocytic anemia. It is ineffective erythropoiesis with intramedullary death. And that hemolysis, intramedullary hemolysis, causing little bit of rise in the bilirubin. What is this patient? How is it different from this one? Can somebody look at this? How is this one different from this? Look at the RDW in
It is not.
No. Moset, and we can see target cells.
Yes, very good. But do you see that much of anisopoikilocytosis?
No.
No, ma'am.
No. Okay. You see target cells. Very good. And you see this. What is this neutrophil?
Yes.
It's a hypersegmented neutrophil. 6 lobes.
Yes.
Right? So what will you think of? I have said this is a typical picture of B12 folate deficiency, megaloblastic anemia. What about this? What will you think of? Sorry? Please remember, these target cells are not hypochromic.
Someone said alcoholic.
No,
The chat
yes.
has written alcoholic liver disease.
Yes. So you will look at liver disease, hepatic pathology. In such a case, you can see acanthocytosis and a normochromic and macrocytic target cell. Very typical of chronic liver disease, alcoholic liver disease, and alcohol we know is direct toxic to the marrow. Plus, of course, it causes B12 folic acid deficiency. Besides this, you have macrocytosis seen in aplastic anemias, but the macrocytosis is not to a great extent. They are just above the normal MCV. Hypothyroidism. Please think of this these days. Many of your patients may be hypothyroid. They will come up with anemia, which is normo or macrocytic anemia. But there is a catch to this. Many hypothyroid patients also have menorrhagia. And they are the ones who are bleeding also. So depending on the degree of menorrhagia or the degree of hypothyroidism, they may have microcytic, normocytic, or macrocytic anemias. Pregnancy usually has a little bit of macrocytosis and hypersegmented nuclei as well. Not to forget myelodysplastic syndromes, which can also give rise to macrocytosis in the peripheral smear. Chemotherapy, of course, marrow defect, marrow depression, causing production defect, production loss, and give rise to macrocytic anemia. So, summing up, B12 folic acid deficiency causes marked anisopoikilocytosis, cabot rings, tear-dropping cells, but a liver disease macrocytosis has acanthocytosis, normochromic target cells, hypersegmented neutrophils, and no hypochromia. From the peripheral smear, you can tell the clinician, please do liver, rule out hepatic pathology, or do a B12 folate estimation. Thus, what we are doing is, if I see a picture like this, macrocytosis, I ask for serum LDH only. Many times we do not have the history or clinical examination sitting in the laboratory. But LDH is the one which becomes my center point in the diagnosis of macrocytic anemias. And that is my algorithm for high macrocytic with a retic. And then LDH decides. If the LDH is not very high, we know 200 to, depending on the laboratory and the method, we take is at 240 as the upper limit for normal international units. Between 250 to 600, I would say, less than 1000. Look at this group of disorder, which is usually non-megaloblastic, will have chronic liver disease, dyserythropoiesis, myelodysplastic syndrome, or aplastic anemias. Whereas LDH high, over 1000, 2000, please think of B12 folate and do the assay accordingly. What we are doing in practice, macrocytic anemia, do an LDH. If the LDH is over 1000, 2000, put the patient on 10 days of trial for B12 injections with tablet folic acid. Response on the 10th day with retic count of 20%, we are very happy. We don't have to do anything else. We have even avoided a bone marrow. But if the response is not very good, on the 10th day, please do a bone marrow and rule out all these problems which are sitting there in the bone marrow. Am I clear? Any questions?
Any questions, students?
No.
Or
No?
Dr.
Okay. Now,
Kashyap, would you like to
yes.
say something about this?
Sorry?
Macrocytic anemia. Dr. Kashyap is here now.
Yeah, Dr. Kashyap.
I mean, a clinician's point
That
of
is
view
the
of
approach we have,
macrocytic.
but clinically and in the
No,
lab, how would
absolutely.
you?
What, ma'am, you have said is very important, especially when you diagnose a megaloblastic anemia. The residents in training
Yes.
should remember to tell the clinician to send a repeat peripheral
Yes.
smear. Now, you
Yes.
have to see the response. Now, if you see a
Yeah.
blunted response, always suspect that the patient is having a secondary megaloblastic anemia. And
Right.
Yeah.
and just always remember that pure vitamin B12 megaloblastic anemias will not have a liver and spleen. So,
Yeah.
in our own experience, we have seen many times that patient initially had a tip of the spleen of 1-2 centimeter spleen, palpable, florid megaloblastic picture, given vitamin B12, but 4 weeks down the lane,
Yes.
weeks down the lane, the peripheral smear started showing blasts, acute
Blast.
lymphoblastic leukemia.
Right.
So,
Absolutely.
so what you as a resident should remember that even if you're seeing hypersegmented neutrophils, please also look at the WBC morphology, screen it properly
Yes.
that least you miss out anything. And if the clinician has said that there is a liver and a spleen palpable, then right away ask them that please, though it is a megaloblastic, please do a bone marrow. If not
Bone
now,
marrow.
if at least a 1 week.
Maybe 10 days later.
Another
Yes.
point which I think I would do it is in a clinical setting in the same, that if there was a
Yes.
56-year-old man who comes unconscious to the emergency room, you send a peripheral smear and a hemogram shows a megaloblastic picture, right?
Yeah.
So, and
Yeah.
I think somebody is from JIPMER on the among the group. So, can you tell me what would be the possible cause of megaloblastic in this patient?
Yes.
A Jipmerite will invariably in day out get it.
Dr. Rajesh, this Jipmer starts with a G. He is from Delhi. GB Pant Institute of Medicine. He is not from
So
Pondicherry.
only Dr.
Yeah, but
Basu
anyway,
is the
Raj.
Dr. Basu is the J. Okay.
Yeah.
No,
I am J. Raj is G. Yeah, Raj. Anyway, what is the thought?
Okay,
What is
okay.
the thought when
So
comes like that?
why I said ma'am listed all the causes, I wanted to emphasize thiamine deficiency megaloblastic anemia. So
Yeah,
in
that's right.
why I
That's
brought Pondicherry into the picture was it's a very good, nice seaside with good facility for the evening sessions with almost all variety of drinks available. So as a resident, we always see chronic alcoholism. So, ma'am, you said that you will see the
Yes.
acanthocytes and all, but classical
Yes.
unconscious state and
Yeah.
having a megaloblastic picture. So it was an algorithm that you get a patient, and if you get a history of alcohol ingestion, give a intravenous thiamine, and the patient used to sit up,
Okay.
and the patient used to
Okay.
sit up within 24 hours, and then we used to give oral thiamine tablet and iron, and then the patient used to get absolutely get recovered. So if you
Yeah.
get vitamin B12 resistant megaloblastic anemia, think of pyridoxine deficiency and thiamine deficiency. These are two concomitant conditions which will go on.
Thank you, Dr. Rajesh. Thank you. We
Very
have
valid point.
babies. We have inherited thiamine deficiency sometimes,
Yes, ma'am.
and they present with megaloblastic anemia, neonates, babies, children in the toddler age group. So yes, thank
And
you so much for bringing out this point.
possibly one more clinical setting. I just thought maybe I'll tell to the residents. You showed a 60-year-old man admitted into an ICU, history of abdominal pain and a peripheral smear
Yes.
showing basophilic stippling. Now, should I
Yes.
change the case scenario and say that the history was given us as a 14-year-old girl who comes with a history of intermittent and abdominal pain and presents with paraparesis, and we see the peripheral smear, we see a lot of basophilic stippling. So, what would be a condition that you will think of? Neurological setting, abdominal pain, and peripheral smear showing basophilic stippling.
Yeah, I think.
Yes.
Yes. What will you think of?
On the
Any
chat, people
resident?
are answering. People are talking of porphyria.
Someone is
Bring-
telling B12 deficiency, someone has said lead poisoning itself, and someone has said acute intermittent porphyria, sir.
Perfect. Acute
Yes.
intermittent porphyria will be the diagnosis. So in India, we do
Yes.
tend to see acute intermittent porphyria. Hereditary
Absolutely.
protoporphyria is in South Africa, whereas erythropoietic porphyrias are rare. So in Indian setting, if you
Yes.
see this clinical history, young patient with neurological symptoms, abdominal pain, and you see basophilic, lead poisoning one, but neurological
Yeah.
signs predominating, porphyria should be suspected. So you actually
Very
tell the
good.
clinician to think of a porphyria and do the test. So what will you do the
Yes.
lab test for a porphyria?
Come on, residents.
Anyone?
Anybody?
Anybody, what will you do? What will you test?
Someone has written urine porphobilinogen.
Okay.
Yeah. Yeah. Okay.
Actually, it is a bit difficult, but you get this. You measure the delta aminolevulinic acid levels. That's an enzyme
Acid.
which is the
Yeah.
actual level
Yeah.
will be the deficient.
ALA, delta.
ALA. Okay.
AL.
So just remember, protophyria also has a clinical condition which will present with a basophilic stippling. So that's very important.
Yeah.
Neurological signs, basophilic stippling. Think of a porphyria.
Thank you.
Yes,
Thank
ma'am.
you, Dr.
Thanks.
Thank you so much. Yes.
Ma'am, there
Thanks.
are a couple of questions related to macrocytosis.
Yes.
So one person is asking, in chronic lead poisoning, can there be normocytic normochromic anemia too? Normocytic anemia too?
Yes, of course. It can be normocytic. It can be microcytic. Both.
Both.
Yes. Yes.
And
It can be there.
then there is a question asking about LDH level after 10 days of treatment.
LDH level starts falling. But it will still remain high. It is high, but it starts falling within 24 to 48 hours of starting the therapy.
So, ma'am, one of them has asked, Dr. Ashish Gupta has asked, free vitamin B12 levels and total vitamin B12 levels.
Yeah.
The question is not clearly specific, ma'am. They have just asked about it with a question mark. That's it, actually.
Yes.
The difference, they're asking what is the difference between free vitamin B12 levels and total vitamin B12 levels.
Yeah, free is the one which is the cyancobalamine which is circulating, but it's not measured, otherwise it's unstable. Hello, am I audible? I see some disturbance.
You're audible, ma'am. You're audible.
You're audible, ma'am.
Okay. So normally what we are doing is we are measuring the total B12. Many times you will see reports of more than 2,000 in a patient whom you're suspecting to be having B12 deficiency. It is like high ferritin. It is the disuse. It is not being utilized properly in the incorporation of hemoglobin, that you have this accumulating and it is not being used in effective erythropoiesis. And that is why many patients of neurological symptoms of B12 deficiency do benefit with injections of B12.
Okay, ma'am.
Is that clear? Okay.
Yes.
Okay.
Ma'am, Dr. Nandini is asking, should we report occasional macrocytes on smear? How much percentage of cells on smears do we decide is predominant cell type? These are the two questions by her.
Look at your MCV. See, all the machines are giving you an MCV of an average of all the cell types. It will never give you, if machine is giving you macrocytosis, that means you have a fair number, a large number of macrocytes. But please remember, in many cases of dimorphic anemia, the machine is just giving you one normal MCV. But if you look at RDW, that will tell you how much is the variation, how big is the difference between the sizes. So one has to look. If it is really macrocytosis of, you can't give a number like that, but definitely if the machine is giving you a macrocytosis, it is definitely significant macrocytosis. Few macrocytes are seen in sometimes iron deficiency, lots seen in pregnancy, chronic anemias, malabsorptions. Those occasional few ones are not making it macrocytosis. Shall we go ahead?
Yes, ma'am, we can go ahead, ma'am.
Okay, coming to certain other disorders. Now, looking at the smear of this first one on the left side shows you marked anisopoikilocytosis, polychromasia, NRBCs, and that is the classical picture on the peripheral smear of beta thal homozygous. Mainly very hypochromic cells. Next, you have this. Sickle cells. You can definitely see the sickle cells, but many times they may not oblige you by showing themselves on the peripheral smear. You have to suspect them. Please remember, typical sickle cell is usually 2 to 3 times the RBC normal, a fully hemoglobinized cell. Even a smaller cell, fully hemoglobinized, is very suspicious of a sickle cell disorder. And if you see a smear like this, these are the tactoids, the rectangular looking cells, but they are fully hemoglobinized. They will also, if you can't call them sickle cells, but they are definitely telling you, please look at your sickling test. And this is also a case of sickle homozygous. It can present in different ways. You may have no sickle cells in your peripheral smear, or few fully hemoglobinized cells, or tactoids presenting like this. Coming to the crystals, hemoglobin C crystals and peripheral smear, we don't see many in Indian subcontinent, but you do see them in the other parts of the world. And you see that the highest number of target cells are seen in this disorder with this kind of crystals. Coming to red cell enzymopathies, red cell fragmentation, these are all cases of hemolytic anemias. You can see that there are bite cells, half empty looking cells with the membrane empty looking half. This is very typical of a bite cell, and this is typical of a G6PD deficiency. PK deficiency, we have seen cases in children, neonates, who give rise to pycnocytes like this. They're small pycnocytes, fully hemoglobinized, and with NRBCs showing hemolysis. All these cases are the ones which have a face of hemolysis, and many of them are themselves telling us the diagnosis as well. So you have to be very careful and try and investigate any hemolytic disorder by looking at the morphology of these cells. These G6PD white cells or blister cells are like this, half empty looking, and are very diagnostic of G6PD deficiency. So whenever we are suspecting a hemolytic anemia, these are the number of investigations that we must advise after looking at the peripheral smear. Hemolytic anemia of thalassemia major. You do the HPLC, show the presence of fetal hemoglobin. Sickle, you show the presence of sickle band. And that is how you proceed further in all these cases. That is how hemolysis should be tackled after seeing the peripheral smear. I have a child, 6-year-old, please pay attention, 9.8, he's anemic, WBC is high, platelets are low, and has a blood picture like this. Anybody wants to put a comment on this, please?
Yeah, any one of the students? Sujit?
Blood cell.
Something more than hemolytic, Swati? MDS. 19,000 TLC, yes. Shibu, what's your thought?
Uremia.
Any specific
Good.
entity?
Somebody
in the
said
peripheral blood?
uremia.
Yes.
So what are you thinking of when you think of uremia and this structure in the center?
Blood cell, madam.
These are schistocytes.
These are schistocytes. Many people, ma'am, on the chat wrote as microangiopathic hemolytic anemia, schistocytes.
Very good.
Quite
I'm
a few people
so
on the
glad.
chat and yeah.
So glad. Now this schistos means it's a Greek word that means divided or schistine or split cell. And they are also called chitos, that is schistocytose cell. It's a hollow cell. It's a fragmented red cell, irregularly shaped, jagged, and has two pointed ends. But the most important feature that they do not have a central pallor. Please remember, you will see many pointed poikilocytes in iron deficiency in any number of conditions.
Thalassemia, yeah.
But yes, thalassemias, but they are not called schistocytes because they are not fully hemoglobinized. They do not have a central pallor, schistocytes. They're also called helmet cells. They're triangular, comma-shaped, pointed edges, like this one here is a schistocyte. This here is a schistocyte. And These are all the phases of schistocytes, which are the features of microangiopathic hemolytic anemias, which are 3. Depending on what is your clinical setting, you will ask for urea estimation, and if it's an elderly person, TTP or disseminated intravascular coagulation. All are in microangiopathic hemolytic anemia, correlate clinically with your patients. What are the investigations you will ask for? Do the coag workup, do the D-dimer, renal function test, and other things. Quickly coming to other elliptocytosis, other red cell disorders. If you
I
have
think there's a
more
background, ma'am. There's someone talking in the background.
yes,
Sujit,
I
I think
think
it's
so.
you. Sujit, please unmute yourself when you are talking to someone else.
I think, ma'am, you should also just let the residents know what should be the percent of histiocytes to suspect TTP and HUS.
Yes, ma'am. We need to talk a bit more on TTP.
I am not elaborating too much because I have so much to talk
Yes,
about.
but
Yes,
I think
yes,
this is a very
you
important
can.
point, that the
Yes.
cutoff levels before you say that the patient is having a definitive
Yes, ma'am.
schistocytosis for a HUS TTP.
Yeah, but what happens, we have seen that in children especially, you may not be able to quantify them, but they are still very significant. And at the beginning of a microangiopathic hemolytic uremic syndrome, especially in pediatric age group, even 1 or 2 per oil immersion field are very significant. So normally I have stopped counting. I go by the platelet count, I go by the WBC showing toxic changes, and I go by even a few schistocytes. Immediately tell them to be wary, especially in children with hemolytic uremic syndrome. Yes, for other disorders, yes, quantifying more than 10, they give it as percentages. So it all depends on how you go about it. But I feel once you see a schistocyte and thrombocytopenia, please don't ignore. The number may not be very important.
That's important because the ISLH guidelines say that even 1% of schistocytes in a setting of microangiopathic hemolytic anemia with thrombocytopenia must be reported on. Because this, ma'am, is actually important, as Dr. Rajesh said. This is something that the residents must be able to pick up because it is one of the critical care reports, very critical reports, because treatment, if it's not treated early, especially TTP and HUS, it can be a fatal disease.
Absolutely.
To identify microangiopathic hemolytic anemia with absolute as much certainty. And there are those, for DIC, there is a DIC score, and for TTP, there is a plasmic score. So all those things have to be taken into account.
Yes. We see a lot of HUS patients. We have a very good pediatric department, so they keep us on our toes. And we have to look for the schistocytes. Even if I see 1 or 2 per oil immersion field with thrombocytopenia, I immediately tell the clinician or the pediatrician, please take care of this child, get a urea create done, and please look for hemolytic uremic syndrome.
Another investigation that actually needs to be emphasized is the LDH levels.
LDH, of course.
So the algorithm is, especially in this condition, is a very strong clinical and lab correlation. So suppose if you get an elevated LDH, D dimer may or may not be positive in both, but PT-APTT is normal. LDH is elevated, schistocyte is present, then you say TTP HUS. And if you find that the LDH is low or it's in the normal range, and you find PT-APTT dearranged D dimer, then think of more of a DIC and progress.
DIC, yes. Absolutely. Thank you for bringing out this point. I'm not elaborating on individual conditions, but
because I just
it is
wanted
important.
it, because most of the residents here in training are working in a tertiary care hospital, so I think so they are the ones who will guide their ICU teams.
Absolutely.
So,
Thank you. Thank you so much. Thanks a lot. So elliptocyte, I'm still on RBC disorders. If they are more than 25%, you can think of an inherited condition. Otherwise, elliptocytosis can be seen in many acquired conditions. So give an importance to it. But please remember, hereditary elliptocytosis is a hemolytic anemia and can present as an anemia of chronic disorder sometimes. All these conditions can show you some degree of elliptocytosis. Stomatocytes, that is mouth-like opening in the RBCs, they can be seen. Again, can be inherited, but I go by electrolyte imbalance. If I see in an adult stomatocyte, alcoholism and electrolyte, they are top on my list. And I ask for electrolyte test and ask them to do some liver function test. These are some other poikilocytes that RBC disorders we can see. I'll quickly cover anemia in the neonates, which is a very special population. And we know that this anemia can be due to hemorrhage, hemolysis, or inadequate production. Please remember this point when you're looking at the neonates. In day 7, the retic count is very low or should be low. There should be no retic at day 6 to 7. In other words, when we are looking at the peripheral smears, you should have no polychromasia. No polychromasia in a day 7-old baby. And that is the reason for your physiologic anemia that you have, which is due to marrow shutdown at day 7. And that is a very important lead when you're looking at hemolysis in a term neonate. The defect can be due to any of these reasons, and the anemia can be of any of these reasons. RH incompatibility, ABO, minor blood group, or maternal autoimmune hemolytic anemia. Look at this baby and tell me if the baby is hemolyzing or not. Day 1 neonate, HB. I put it in red. I should not have put it in red. Day 1, 11 gram is definitely anemic. Platelets are low. And day 1, 8, but 5% retic, 6% retic at day 1 is normal for a neonate, please. 8 is little more. That is the blood picture. Anybody comments?
Anyone? Namrata? Spherocytes,
Yes.
right, Siddhi?
Yes. Spherocytes. Excellent. What are they trying to tell us? This baby is probably having spherocytic hemolytic anemia. Cause.
What could be
Here
the
is
cause in
another
a
one.
newborn?
In the newborn.
Before you think of hereditary spherocytosis, some other cause?
Hereditary, before.
Even autoimmune is unusual. People are writing autoimmune hemolytic anemia. That's unusual in a newborn, isn't it?
ABO incompatibility.
Yes. Some people in the chat box are saying ABO, ma'am.
ABO, yes. ABO incompatibility has spherocytic hemolytic anemia. Usually the mother is the one who is O and the baby is A or B. In hemolytic disease of the newborn of RH, you have polychromasia, NRBCs, but spherocytes are not the predominant cell. And usually it is very severe, and the sphere shows erythroblastosis. Here it is usually spherocytosis, which is more prominent, depending on the degree of hemolysis. DCT may be positive, may be negative in ABO incompatibility, because you have to do a special DCT, which is of eluting the technique, which is doing the DCT after isopropanol elution, that you expose the cell antigen and then you will get a DCT. So that is a very typical picture of ABO incompatibility versus Rh incompatibility, which does not have spherocytosis as the principal cell in the peripheral smear. So spherocytes in the newborn, of course, hereditary you will think of, but before that, think of these conditions. They can all cause spherocytic hemolytic anemia. You will ask for antiglobulin tests, osmotic fragility. One important thing about osmotic fragility, it will depend on the number of spherocytes. You may have a normal osmotic fragility if the number of spherocytes have already ruptured and you have very few spherocytes in the peripheral smear. You have more of polychromasia and reticulocytes. The osmotic may be normal. Please, you have to go by your smear reading.
Just
Here
one
is a
question, ma'am.
child.
What would you do if your OFT is normal, but you're
Sorry?
suspecting spherocytosis? What
You
would
will
you
have a
do if
look
your
at your
OFT is
smear.
normal?
Osmotic
No, I'm
fragility,
asking
if
them
it is.
anything else they can do. Anything else they
Yeah,
can do.
yes. Yeah, what can they do?
With,
Tell me.
what is the next step to a normal osmotic fragility? You are aware of something called an incubation fragility
Incubation.
test.
Yeah.
Okay, you incubate the blood for 24 hours and run the test again. The 24-hour period, the blood becomes spherocytic, whichever are there. Just because they are stored, they become spherocytic and your test becomes more spherocytic. Spherocytosis is exaggerated. And so your test comes positive. Your osmotic fragility curve shifts to the right. Yeah. Okay, ma'am, please carry on.
Okay. And if you have hemoglobin urea, then you're looking at autoimmune hemolytic anemia, in which case also you will have spherocytosis. This is a child, jaundice, moderate splenomegaly, thought to be having storage disorder, hemoglobinopathy. This was the blood picture of this child. He had anemia, WBC normal, platelets normal, retic was little high, had bilirubin, which was borderline high, indirect type, and that was the blood picture. So we did to rule out hemoglobinopathy. Electrophoresis showed AA pattern. That was we did a marrow to look for the storage cells because there was splenomegaly. Now the child came back again, and this time we saw a lot of polychromasia with spherocytes. One important point to remember, hereditary spherocytosis is the most missed diagnosis. If you see a smear like this and the child is not in an hemolytic crisis state, you will miss your spherocytes, which may be very few. How will you recognize a spherocyte? Because that is the diagnostic test or suspecting a case. Now look at this smear in an area where there is little overlapping of the red cells. The normal cell should have a central pallor if it is lying single alone. But if it is sitting and touching each other, they will lose their central pallor. However, a spherocyte sitting alone will show you no central pallor. Please look at this spherocyte. This is a normal cell. And that is where we miss spherocytosis in cases who are not in acute hemolytic state. This child later on showed us like this with polychromasia and the spherocytes. But by that time, we went back to the smear and saw. We did the test for eosinophil melamine, and then we diagnosed that it was hereditary spherocytosis. Most missed diagnosis. Coming to anemia of the newborn, what is my algorithm? I go by retic count. Newborn. As I said, day 7 should have no reticulocytes, no polychromasia. But if the retic is low, newborn baby, day 1 to day 2, think of a marrow failure. Later on, if it is there, then you will look at other reasons. If the retic is high, look at hemolytic disease of the newborn. And if the direct Coombs test is negative, please look for certain other morphological abnormalities inherited, which may be in the newborn period. If there is jaundice, look for certain other reasons like bacterial infections, congenital sepsis, galactosemia, inherent errors of metabolism, and of course the enzymopathies. So the retic count is the one which is the central point for us when we look at a neonatal smear. Coming to what you see here, what do you see here?
Bodies.
Anybody?
Siddhi, what are you saying?
Is it hypochromia?
Hypochromia, yes, there is hypochromia.
Something else? Something
Owl
else?
jolly.
Howell jolly bodies, yes.
Right.
You can see the Howell jolly bodies in these two RBCs. This is the signature of hyposplenism, can be due to congenital absence, atrophy. Please, celiac diseases cases can also show you few Howell jolly bodies because of low splenic activity. Deposition of amyloid in spleen. And please, this last point is very important. When you have a patient who has been splenectomized for ITP, the appearance of Howell jolly body is very sinister. It tells you that the accessory spleen has come back if they disappear from the peripheral smear. Very important point. If the Howell jolly bodies in a splenectomized baby child disappears in a case of ITP, you should suspect an accessory spleen which has come up. So these are all reasons for Howell jolly bodies and the importance of it. Coming to the last point in RBCs, the arrangement or relationship with each other. Yes?
This is a
Rouleau formation.
Rouleau formation. Good. And the reasons for Rouleau formation?
multiple myeloma.
First reason. Will you suspect multiple myeloma in a 10-year-old child if you see this picture? No, because it is an indicator of low albumin. Rouleau formation is the reversal of the AG ratio. Please remember, it is not just myeloma protein. It is because the albumin has gone down and your globulin is more, which can be due to low albumin, which happens in malnourished children, or in chronic liver disease, hypoalbuminemia, and that is a very common reason in children and adults. But yes, myeloma, if you're suspecting in an adult. We have seen 25-year-old myeloma patient. We saw this Rouleau formation, told him to do serum proteins, and turned out to be myeloma to my surprise. I was thinking probably he'll be of low albumin and chronic liver disease. Coming to this, anybody? What is this peripheral smear showing?
Autoagglutination.
Autoagglutination, very good. Now this autoagglutination is seen, it increases the suspicion that there is an agglutinin which is present, and usually seen in cold agglutinin disease, which can be due to mycoplasma pneumonia, infectious mononucleosis, lymphoproliferative disorders. If you see erythrophagocytosis, can you appreciate it? This cell has eaten up 2 RBCs. Erythrophagocytosis, if you see, and it is usually a feature of paroxysmal cold hemoglobinuria, and of course autoimmune hemolytic anemias. So they are talking about the relationship to each other. They are agglutinating. and they're eating up something which they are not supposed to eat. Any questions on RBC disorders? Can we proceed? We are going very late. I hope I can continue.
Yes, ma'am.
Yes, ma'am.
Yes.
Okay, coming to the leukocyte disorders. Neutrophil leukocytosis, neutrophils we know very well. We know that a WBC count. I give a lot of importance to eosinopenia. Please mark my word. As I go along my talk, you will see that these friendly looking eosinophils, when they disappear, they are the ones which create havoc in my diagnosis. Such is the picture. And if you see a picture like this with a normal WBC, monocytes, eosinophils, start thinking of CRP positive. It may be Shigella. I see this salmonella infection, monocytosis, toxic changes, eosinophils not there. So please, in PUO cases, WBCs are very important. If you see neutrophilia, toxic changes, acute inflammation, but if eosinophils are still seen, you will think of maybe urinary tract infection. Many pregnant patients can show you some toxic changes, but high counts are quite normal in normal pregnancy, but not this high, 20,000. So urine tract or urinary tract infections can cause neutrophil leukocytosis, but the eosinophils still be there. If they disappear, then you are dealing with acute inflammation, which is bacterial, like abscesses, necrosis. They are the ones which cause neutrophil leukocytosis without eosinophilia. If eosinophils are seen, we have seen patients of malignancies, necrosis in the body, going to almost leukemoid reaction, kind of a picture of 80,000, but they do show eosinophils. Think of necrosis in that body. And we have diagnosed malignancies on this basis. Eosinophils, if not seen, look for abscesses in the body. Of course, shift to the left with chronic myeloid leukemia, everybody is quite familiar with. You have basophilia, you have eosinophilia, and all the shift and the complete maturation of the myeloid series. Usually you will think of a chronic myeloproliferative disorder. Coming to the WBC inclusions, toxic granulations and Dole bodies. Very important. Do you see this blue thing in the cytoplasmic, usually around the membrane? Plus, we'll come to these conditions a little later. If you see Pelger-Hewitt, what is this? A Pelger-Hewitt anomaly?
Binucleated neutrophil.
Binucleated neutrophil
Predominant.
called Pelger-Hewitt. If more than 25% you see in a smear, likely to be inherited, it's an autosomal dominant trait. You can have people in the family, I have seen this running in the family, and they have no other abnormality of the function of the neutrophils. But yes, they can be seen few in MDS, Fanconi's, and myelotoxic drugs, mononucleosis, myxedema, and many other conditions may show you few Pelger-Hewitt cells. Sorry, I'm running a little fast. Otherwise, but any question, please stop me. Anybody on these? Morphological changes and neutrophils? Any questions? Any thoughts? Okay, coming to WBC's lymphocytes. Normal range, we know 1,000 to 3,500 per cubic micrometers. That is the normal absolute lymphocyte. More than 5,000, we think of lymphocytosis, which is usually seen as reactive, self-limiting viral infection, mononucleosis, and chronic inflammatory conditions. You can think of leukemia and occasionally lymphoma, but many cases in adults, if you see small lymphocytes, it is chronic lymphocytic leukemia, especially if you see them in the age group of 60 to 80. They may not be having any symptoms, and chronic lymphocytosis. This is a 19-year-old boy. I want your thoughts on this. Rash, lymphadenopathy, hemoglobin, WBC, platelet. And that's the blood picture. Anybody? Anybody?
Any of the
That is
participants
the board.
talk your opinions?
Anybody? Or should I run through? What will you call cells?
Infectious.
Yes.
Infectious mononuclear.
Muttering a little bit. Young boy, sore throat, body ache, rash, cervical lymphadenopathy, mild thrombocytopenia, high WBC, normal HB. With this kind of a picture, you will think of atypical lymphocytes which are present, can be seen. You will ask for, of course, the heterophil antibodies, SGPT, CMV, of course, and you can have ask for EB virus, nuclear capsid antigens. But if you see these cells in a neonate, you will think of these conditions. But in a child, same picture will give rise to different kind of diseases. And in adults, it will have different meanings. So it all depends who is your patient. Can be anywhere from inflammatory to lymphoma spillover in the blood, depending on who is your patient and which way you will proceed for investigating that case. Yes, please. Okay, dengue, we are all very familiar with dense blue cytoplasm, atypical cell, thrombocytopenia, and they may show a band cell. This is a very classical picture of dengue fever. Now the season is coming up. Other lymphocyte disorders can be hairy cell leukemia. You may see hairy processes. This is a variant of hairy cell where you see large number of them. Normally you see pancytopenia and you can hardly make out any lymphocytes with processes. This is a variant. Prolymphocytic leukemia with a very prominent nucleolus. These are all lymphoproliferative conditions. If you see them in the peripheral blood, you know which way to proceed for these cases. This 7-year-old child had fever, rash, anemia, borderline platelets. What will you call this differential? That is the differential which I have seen many times people making a lot of mistakes. This is the HB, that's the platelet, that is the differential. How will you interpret this differential? Anybody? What would you like to know?
TLC.
Will I call it neutrophilia? Or will I call it lymphopenia?
Lymphopenia.
Why?
Oh.
Why lymphopenia? Why not neutrophilia? Please remember, this is one thing which I have been noticing over the years. People sitting on the counters and making this mistake. The interpretation of this differential count depends on your WBC count. Depends on your total WBC count. Residents don't make a mistake of calling anybody neutrophilia. There is no ilia here. There is nothing which has increased. In fact, the WBC is low. So you have to answer why it is low, because of lymphopenia. Is that clear, or anybody wants to ask a question? Don't ever make this mistake. This differential has to be interpreted in the light of your total WBC count only. If it was 33,000, I would have called it neutrophilia. Is that clear? Anybody wants to ask any question? Now, lymphopenia, we know, can be due to number of reasons, and you must see, because we are seeing it more and more these days. And these are all the reasons for lymphopenia. You have to see who is the patient and in what condition that the patient has come to you about. In COVID cases, we had this algorithm which was working a lot. A moderate lymphopenia they thought was more than 20%, and they felt that these was curable, but I don't know how much this thing helped in those cases. Coming to you, any thoughts on lymphocytes? Anybody? Okay. Eosinophilia. Secondary eosinophilia caused by a whole lot of conditions. Can be parasitic, drugs, asthma, allergic vasculitis, lymphoma, metastatic carcinoma, and you have the whole group of disorders for eosinophilia. Please, my question is, in pediatric age group, we see a lot of pediatric good cases. Please look at this case. I am going to show you 3 very important cases in pediatric age group who presented with eosinophilia. Besides all these conditions which you people must keep it in your mind, and who is your patient, please, if any of you are sitting in a pediatric setting, don't forget these cases. This was a 7-year-old child, low-grade fever, had anemia. You can see some kind of hypochromia. There was moderate, mild hepatosplenomegaly. WBC was high, 35,000. Platelets was lower side. And the smear showed that because the WBC is high, I'm calling it eosinophilia, which was 76%. You can see on the smear. There were occasional atypical lymphocyte, did the stool examination of this child, but did not show any parasite. He was clinically put on heterazan for 10 days. There was no response. The pediatrician insisted, marrow kar do, madam. I said, क्यों करें madam? इसमें कुछ reason ही नहीं है marrow करने के लिए. But he insisted and I respected his view. Look what we found. This biopsy, and that was the aspirate. More than 70% cells were either blast or eosinophils mature. Can you see this? Very peculiarly seen in the childhood states of acute lymphoblastic leukemia. They can present as only eosinophilia. Don't miss these cases. We probably missed a few in this peripheral smear. If we had looked more carefully, we were so taken up by the eosinophils, we never bothered to look at the morphology of the lymphocytes. Second case, 2-year-old male child, fever, loss of appetite, anemia, microcytic, platelets normal, WBC is high, 72,000, again eosinophils, had serum enzyme high, SGPT high. We did a marrow because the doctor insisted that do a marrow. This is some eosinophilic leukemia probably. We did it reluctantly. The marrow did not show anything. It showed increase in eosinophils, normal erythroid megakaryocytes, myeloid hyperplasia, no leukemia or lymphoma. But since the liver enzyme were high, we said hepatomegaly is there. Why don't you do a liver biopsy? So he was reluctant to do the liver biopsy. And what we did insist, and what did we find? Capillaria hepatica sitting in the hepatic parenchyma in the form of granulomas. Please, this was a toddler, 2-year-old child. How did he get this parasitic infestation? So caught hold of the mother and asked her. She said, नहीं ऐसा कुछ नहीं है, मिट्टी खाता है कभी कभी. लेकिन हमने कहा आप रहते किधर हो? कि हमारा घर है बहुत बढ़िया गांव में, हम तो अपने गांव में पूरा लेप करके रखते हैं, हम नीचे रहते हैं. It's a ground floor little whatever is there, hut or whatever house you can call it. मैंने कहा तो फिर? कहते उधर वो, मैंने कहा कोई जानवर है आपके घर में? कहते हाँ चूहे हैं बहुत, उधर नीचे आते रहते हैं गांव में. तो ठीक है, चूहे की. He said हाँ कभी कभी वो चूहे का वो जो ड्रॉपिंग्स होते हैं ना, स्टूल, कैपिलैरिया हेपाटिका is seen in the stool droppings of the rat, which if eaten goes into the intestine, goes into the liver to form granulomas. And that is what this child was eating, harboring this capillaria hepatica, hepatic pathology. Third child, 11-year-old, he came with huge blue-colored patches. He had ecchymotic patches, spontaneous, and the parents were worried कि आज तक इसको भी ऐसे bleeding clotting disorder नहीं हुआ. कोई past history नहीं, कोई organomegaly नहीं, कोई family history नहीं. He had eosinophilia, WBC high. उसको भी hetrazan दिया 7 days. That was the complete coagulogram of this child. He had only bleeding time prolonged. Why did I do a bleeding time? Any bleeding clotting patient who has a normal platelet count, I give an importance to the bleeding time. And that is how I said, please do a platelet function test, because he was clinically having huge hematomas, ecchymotic patches actually. And that was the platelet function test. There was no aggregation with collagen, reduced with ADP, and with ristocytine, it was normal. I didn't know what it was. I knew this was abnormal. And then those days, we had a colleague who had just come from Vellore. He said, Madam, ye to happened, acquired platelet dysfunction with eosinophilia. Till then, I had not heard of this condition. It is a very peculiar disorder which is seen in the Asian subcontinent, seen with parasitic infestations, eosinophilia. They come with platelet function defect. You give anthelmintic treatment, they never come back to you. They become absolutely okay. And that is one thing you must keep. So these 3 cases taught me a lesson that in pediatric age group, do not ignore eosinophilia. It can be beyond parasitic infestation. Monocytosis, lot of reasons are there. Can be reactive, can be absolute, different conditions are there. In neonates, how do we look at in WBCs? The white cell count in neonates, I know most of the time my pediatricians are asking the neonatologist, is the baby septic? So I have to answer that question. How do I do it? We note that the total count is not reliable in the neonatal period. Absolute number of immature cells have no meaning in the neonatal period. You can have low neutrophil counts. Left shift may be there. But what I go by is the band cell to neutrophil ratio. And this is the one which has worked the best with us so far. Many machines, analyzers are there, which are giving you immature to granulocyte ratio, IG ratio. But by the time the immature cells come up, that is myelocytes and others, you have missed the band cells. No analyzer gives you the band cell count. And this can, even in the Stanford Children Hospitals, when I visited, they do neonatal smears manually. They do not depend on the counters. Take home message to all the residents. Neonatal smears have to be seen microscopically by you. Dole bodies, toxic granules have no meaning because if the baby is put under phototherapy, they will develop all these changes. But again, my friendly eosinophils. So if I have this and eosinophilia, how do I go about it? We have worked out Monroe's formula, which says from day 1 to day 5, please pay attention. If you do the band says, you know that neonatal smears are very thick smears. HB is very high. The RBCs are packed together. Come to an area where you can see the band cells very clearly. And that is where you must do your band cell to neutrophil ratio. Do that count if it is more than 0.2 and more. And if you have eosinopenia, that baby is definitely septic. Day 1 to day 5 only, please remember. Look at this. If you do the calculation, ratio becomes 0.25. Importance is no eosinophils. More than day 5, normal band cells are there till day 5. But eosinophils are also there. But after day 5, no band cell should be seen in a normal neonatal smear. WBC may be anything. But if you see eosinopenia and you see band cell, I don't go by the ratio. You look at this friendly eosinopenia, and if the band cells are there, top of that, if you see these circulating histiocytes, they are a very bad sign. This baby will never recover. It's severely septic. So you have to do this every time you see a neonatal smear. Keep in mind their days. But if with the band cells, you see the eosinophils, I feel happy. Probably this is a child which is from day 1 to day 5. And now the eosinophils have appeared. And that is the baby is responding to therapy. I write it in my report. Query responding to therapy. So approach to PUO, we know can be, all these WBCs have a meaning. And we give importance to CRP, SGPT, neutropenia, lymphocytosis. And that is how we work up a complete PUO protocol. Any questions on this?
Yes, ma'am. There's Dr. Harsha who's asking, what is the reference range we should use for neonatal counts? DAISY can be used. Can DAISY be used in Indian setup?
Of course. You have to find your own. We know that babies can go normal WBC up to 25 to 30,000, depending on the maturity of the baby when born. I'm talking of only neonates. Only neonates. So the WBC count may be anywhere from 5,000 to 25,000. But that does not make it leukocytosis. Mostly they are between 10 to 22, 25,000. That is the normal range for WBCs. Okay?
Yes, ma'am. Ma'am, then there is a question in the reference to the previous case. What if the total count in that case was normal? So should we have been giving it leukopenia or neutrophilia?
Which one? Which one?
That
Which
case
case?
with the case with reduced total count, ma'am, 3,300 count.
That is my question. What will you call this?
Yeah, what we will call that as?
You will call it as lymphopenia because something has decreased. Please remember, something has decreased.
Okay,
look at this again, please. Look at this again. You have a HB, you have a platelet, and you have WBC of 3,200. You have to answer why this WBC is low. It is low because the lymphocytes are low, not because neutrophils are high. If the neutrophils were high, you would have had 13,000, 23,000, 30,000 WBC. Something has increased. Here, nothing has increased. It has gone down.
What if the total count
Does
was
that
in the normal range? The question is, what if the total count was normal in the normal range rather than 3,200, like 5,000 or 7,000?
If it is in the normal range also, I will call it, depending on who is the patient. If it is an adult, this differential is not normal for either children or adults, both. If the WBC count was 5,000, 6,000, I will still go with lymphopenia. I will not go with neutrophilia. Is that clear?
Yes.
But if it was 9,000, 10,000, then I would not call it either lymphopenia or neutrophilia. Is that clear?
Yes, ma'am.
Okay.
Ma'am, there is a question. How do we differentiate between reactive lymphocytes versus lymphoblasts?
Yeah. Reactive lymphocytes are the ones which have a deep blue, dense blue cytoplasm. Depending on what type, they have normally abundant to fair amount of cytoplasm. They do not have a high nucleocytoplasmic ratio. That is what you people must go by, the nucleocytoplasmic ratio. You can have small blast, which is totally occupied by the nucleus. Lymphoblasts are the ones may not show you the nucleolus very clearly. So in that case, it can be very confusing. But a blast has a very high nucleocytoplasmic ratio. That is something. Nucleolus may or may not be seen, especially in small site T-cell lymphoblastic disorders. You may not see the nucleoli very clear. Is that clear? Answers your question?
Yes, ma'am.
Okay,
Ma'am, there is
coming.
a question between leukemoid reaction versus leukoerythroblastic blood picture.
Here is leukoerythroblastic blood picture for you. Leukemoid reaction you will use for a leukocytic disorder. You have only the leukocyte shift. You will not have the RBCs like you see here in the leukoerythroblastic blood picture, where you have both immature cells of the erythroid series as well as the myeloid series. That is called leukoerythroblastic blood picture. But a leukemoid reaction is only of WBCs high, 50,000 neutrophil leukocytosis with a shift going up to promyelo, occasional blast is a leukemoid reaction. This is what I'm showing you now is a leukoerythroblastic blood picture in which you do not see much polychromasia of the RBC, only occasional tear dropping, and both the shift of the myeloid as well as the erythroid seen in all these conditions. All these conditions can show you leukoerythroblastic blood picture. Any questions on this? You have to do a bone marrow if you see a picture like this to come to the diagnosis of any one of these disorders. Myelodysplastic syndrome can show you shift to the left up to blast, hardly any polychromasia with band, myelo, and karyorectic cells. In peripheral smears, if you see megakaryocytic fragment, it is a sign that there is some problem, fibrosis occurring in the bone marrow. And of course, if you see leukemic cells in the marrow, I am not very excited because I think when you see them, you know that you're dealing with leukemia. You don't have to really think you need the ancillary techniques, but in non-malignant hematology excites me more in the peripheral smear. If you see an OR rod, you know you're dealing with an acute myeloid leukemia. Many of the cases from peripheral smear, you can make out the molecular changes, like cup-like nucleoli in AML are seen in NPM1 and in FLT3 mutation. That is the sign that it's a good karyotype. So in the peripheral smear also, you can find, as I go along, you will see a lot of inherited genetic and molecular changes. Leukemia in the peripheral smear, they are looking at you. You don't have to look at them. Coming to the platelets. Of course, automated instruments have the problem of pseudothrombocytopenia because of the platelet clumping. Can be due to giant platelets, which machine is not counting. You can see them. So any low platelet count, you have to look at your peripheral smear. Can be due to giant platelets, can be due to clumping of the platelets, or can be due to satellitism. Of course, Wiskott-Aldrich syndrome, we have seen cases because the platelets are so small that the machine is not counting. So you see tiny little platelets on the smear which are not counted, but they're adequate. And that is where you can suspect a genetic disorder like Wiskott-Aldrich syndrome. These are all cases, conditions of false low platelet counts on your analyzers. And high counts can also be there, which can be due to the microcytes going into the platelet channel. Microspherocytes, fragments, cytoplasms of leukemia, bacterial fungi, and reagent contamination, cryoglobulins, all can go into your channel and cause high platelet count. Giant platelets are larger. We know 10% of the platelets are normally giant. But when you see more than 20%, you have to think of a giant platelet disorder, which can be acquired or congenital. Acquired ITP, sepsis, myeloproliferative, lymphoproliferative, and whole lot of these acquired disorders are there, which can cause giant platelets. But congenital, once considered rare, are not so rare. Please keep in mind that if there is a variable bleeding symptom and you have giant platelets, it is not always ITP. It can be inherited giant platelet disorder. And these are often misdiagnosed as ITP. उनकी splenectomy हो जाती है, उनको steroid दिए जाते हैं. And we have a whole lot of conditions which are giant platelet disorders. Now, I am coming to some of the peripheral smear findings which can pick up a genetic or a metabolic disorder. We know that we can pick up the sex of an individual by looking at the drumstick count. Bar body, you call it drumstick. We call it drumstick in the peripheral smear. Bar body is in the epithelial cells, nuclei. So the drumstick count. So you can pick up the sex of an individual from the, normally more than 3% is seen in the females. Men don't have any in their peripheral smear. This was a child. Look at this RBCs, showed so much of acanthocytosis. We didn't have any history. And this acanthocytosis baffled me totally. I said, so much of acanthocytosis in a child. So I showed that smear shows evidence of hemolysis. Look at the polychromasia, so much polychromatophilia and pycnocytes and acanthocytes. So I asked the reported in the smear, advised DCT, beta lipoproteins, because that can be the case of A beta lipoproteinemia, and asked them to rule out PK deficiency, and please inform clinical details. to my surprise, the clinical details came as a 3-year-old boy. 8 grams HB. WBC high, you saw it. Look at the retic, had 25% retic, and that was the picture. Lot of polychromasia, epicnocytes, acanthocytes. That was the picture. So I said, and that was the legs. Look at this baby. It was being treated as rickets. It was non-consanguineous marriage. बच्चे को लेके आए हम लैब में, उसका फोटो खींचा. Bowing of the legs, rickets. Liver was enlarged, coarse texture. But biochemistry showed that he had acidosis. This was a typical case of renal tubular acidosis with the syndrome of hemolytic anemia, which we cannot miss, because this is a condition which picks up a molecular defect. And this is seen in cases of distal renal tubular acidosis. And we sent it to Bombay to IIH, and they did the USIN-5 melamide test for mean fluorescence channel fluorescence, and this test was confirmed to be having a presence of red cell membrane protein defect, can be seen in spherocytosis or acanthocytosis, and this was the example of AE1 mutation, which is seen and which has a renal phenotype. They go to pediatric renal nephrologist. So this is a case you can pick up on a peripheral smear. Look at this. What will you call this? Vacuolations in a neutrophil. These vacuoles are seen in a fresh smear. You can see there is platelet clumping, which is telling you that it's a fresh smear. So in an EDTA smear or a smear which has been in EDTA for a long time, you can have these vacuoles. These vacuoles are called Jordan's anomaly. This was an 80-year-old child, microhypoanemia and vacuolations. So we said, okay, let's find out what's the problem with this child. 8-year-old male was diagnosed as congenital ichthyosis. He had skin problem. Abdominal distension, hepatomegaly, strabismus, ectropion, genovalgum, and pancytopenia. Please look at this boy's skin. He had hepatosplenomegaly and scaly skin. That was the ectropion, genovalgum. This was a case of Dorfman-Panarin syndrome. It's a neutral lipid storage disease, which is present with CDS, inherited metabolic disorder, especially in triglyceride accumulation. And these triglycerides accumulate in the leukocytes, liver cells, muscle cells. You can pick it up from your peripheral smear and work backwards to the diagnosis. They have weakness, cataracts, hearing loss, and intellectual disabilities. The defect is in ABHD5 gene, which causes triglycerides to accumulate. Hunter lymphocytes, mucopolysaccharides, we are very familiar with. Do the urine test. You can pick it up from your peripheral smear. This child had these vacuolated lymphocytes in the peripheral smear. And these lymphocytes you cannot miss if you are watching a good made fresh peripheral smear. In the bone marrow, he had these kind of reticulum cells and was found to be having gangliosidosis GM1, which is an autosomal recessive accumulation of gangliocytes. 11-year-old male baby, oculocutaneous albinism, cervical lymphadenopathy. He's had splenectomy. Look at this boy. He had huge, can you see this bulge here? Huge cervical lymph nodes. We didn't know. He just saw the blood picture. That was the anemia. He had lymphocytes which were there. Neutrophils were lower side, and it showed inclusions inside the lymphocytes. In the peripheral smear, cytoplasmic inclusions were seen, which was seen in the bone marrow. We did a marrow and saw them in the marrow as well. This was a case of Shediac-Higashi syndrome, which is having immunodeficiency, inclusion bodies in the peripheral smear. You can pick it up from the smear. This showed the Howell Jolly body. That means this boy was splenectomized. Why did he have the lymphadenopathy? He had Hodgkin's lymphoma. They are immunodeficient, very prone to having lymphomas. This child had CD15, CD30 positive lymph node showing Hodgkin's lymphoma. Histology of the hair, he had golden hair. And we did the histology, showed this clumping of the melanin, which is also very typical in cases of all these metabolic disorders with gray looking, golden looking hair. Shediac-Higashi syndrome. You can pick it up from your peripheral smear. Here is the case. Again, we saw this neutrophil, giant platelet, and what is this? I showed you just now.
Anyone?
Anyone? Quick. Dole body. Dole body, I showed you just now. So Dole bodies with giant platelets, 7-year-old child, frequent bleeding disorders. Platelets were low, number of giant platelets and Dole bodies. Wow, this is a case of macrothrombocytopenia with leukocyte inclusions, these Dole bodies. These are picking up a MYH9 molecular defect. They are MYH9 disorder, rare disorders with giant platelets, thrombocytopenia, and Dole body-like inclusions. We recently had a case whom we sent for molecular testing, and they confirmed this genetic mutation. They can have these inclusion bodies inside the neutrophils. They are part of these disorders, May-Hegline, Sebastian, Fechner, and Epstein syndromes. They are usually transmitted as an autosomal disorder, and May-Hegline can be seen like this. So please look at your smears carefully. Folks, you can pick up everything in hematology. Everything. Pancytopenia, when you come, few cases. What will you call this? Again, is this lymphocytosis or is this neutropenia? Will depend on your WBC count. Please interpret it very carefully. This is a classical case of aplastic anemia. You have everything low. That was the marrow. But in an hypersplenism, the differential count is maintained normal. Please remember this point. You may have pancytopenia, but with a normal differential, hypersplenism of chronic disease. From peripheral smear, you can pick up all your parasites. I'm sure all of you have seen all of them. One thing that sometimes treated malaria may come to you, which may only show you this hemozoin pigment in some of the monocytes. You may not see, but you know the signature. And you can say probably a recent malarial infection. You can see Vivax, falciparum, trypanosomes, and microfilaria in your peripheral smear. This case is my favorite. Pay attention. 62-year-old man, hypertension, no family history, had giddiness, vertigo, and admitted in ICU with stroke. Painful bluish fingers of the left hand. He was unconscious. No organomegaly. Neurologist was consulted for stroke. Vascular surgeon for bluish discoloration of the fingers, and a hematologist because of thrombocytosis and leukocytosis. All workup done for collagen, myeloproliferated, thrombophilia, marrow done for MPN. Everything was normal. All thrombophilia workup. So the differential diagnosis for vasculitis, chronic myeloproliferative, put on hydroxyurea, and he recovered. 15 days later came to us for a follow-up. Again, the platelets were high, but in the peripheral smear, I saw one cell. One cell. Please pay attention in the peripheral smear, which I had ignored probably the last time when I saw his peripheral smear. And a Howell Jolly body. What is the significance? What am I dealing with? 60-year-old man? Am I going to call him sickle homozygous? But yes, that is what he was. He had 62% S in HPLC with 38% fetal hemoglobin. This was protecting him throughout life, not to sickle. This was the first time. And when we asked him, had he ever flown? He said, "Main to flights mein kitni baar ja chuka hu. I get headaches, but I have never had any episode." This was the first time he landed up in ICU. There was no spleen, absence of spleen. We had Howell Jolly body, but picked it up only on a peripheral smear. My request to you guys is, please pay attention, correlate your cases, look at everything very carefully with an open eye. Don't have a bias. This is a fresh smear. You can see the clumping of the platelets. So this was a case of, we have an Indian subcontinent association of sickle gene with alpha gene deletion, which protects them by making more fetal hemoglobin. And they, of course, are sickle homozygous, but they have, this is post-autosplenectomy, and the thrombocytosis was due to splenectomy. This was a very interesting case, 32-year-old female. Why I'm saying is that plasma defect can also be picked up in the peripheral smear. Look at the areas in between the red cells. You can see the hypertriglyceridemia on the peripheral smear. She is a familial case of hypertriglyceridemia. It was recently seen in Bharti Vidyapeeth. I think Sri Lekha will remember this case.
Yes,
So my message is, please look at your CBC data as an organ, correlate very well, look at the morphology, interpret properly. You have to observe, analyze, correlate. Look at this detective work. It is a whole book of hematology in front of you. I always give the example of Zadig. You know who Zadig was? He was an Arabic monk. He was working in the king's court. And he had a huge power of observation. So the king asked him once that, Zadig, I think my wife is unfaithful. The queen is having an affair. And she goes and meets somebody outside, but I am not able to find out. He said, can you find out? So Zadig, after months, came back to him. He said, yes, sir. Your wife goes out every night, meets somebody outside the palace. How did he know? Because he could see the heel marks of the sandals of the queen with a gown which was taking the sand along with it. And next to the gown mark were the feet of an animal, cat. In between the cat's paws were a line. He said, this is the cat of the queen who has delivered. These feet are making that line in the middle, and the queen takes the cat, goes outside to meet somebody. This was the power of observation. My folks, I want you people to develop the power of observation to interpret your hematology. Thank you so much. Any
Thank
questions?
Yes, ma'am. There are a couple of questions that we can take. So initially, Lucky Avi has asked how to differentiate the blast from therapy-related changes in cells in post-induction therapy in leukemic case.
A blast is a blast. Wherever you see it, you should be able to characterize it. Whether therapy-related blast or are you talking of hematogones? No.
They have not
Blast
mentioned
is a
clearly,
blast.
ma'am, but then they have also asked how to give a differential count and give a
You
blast
can't
count in
see me. Sorry. Somehow my camera has gone. Anyway, yes.
Yes. Again, the same person has asked how to differentiate, give a differential count when it is a severely leukopenic patient.
Oh, I do a 50-cell differential. I spend maybe 15 minutes on that smear, but I do it because it gives me more information than anything else. Then
one doctor has asked, what is the difference between RDWCB and SD? And which is the one that should
these
be
are
used
the
to
two
calculate thalassemia?
units. These are the 2 units of measurement. So you can show your RDW either way, either as the percent or as the CB, whichever way.
Okay, ma'am.
I don't know why my camera is not working, but it's okay. It doesn't matter.
It's okay, ma'am. No issues. There is a question when there is a normal hemoglobin and RBC is normal or high, but the MCV indices are in the low range. What should be the RBC description given as?
Ma'am, are you there?
Ma'am, I think.
Please unmute yourself. You're muted, ma'am.
Ma'am, you can stop sharing and come out. Please stop sharing, ma'am. Yeah. I think ma'am has gone off.
Drop the call. Probably the call is dropped, sir.
Ma'am is muted.
Wait.
Yeah.
Yes.
Yeah, ma'am is back.
Yeah.
Can you hear me?
Yes, ma'am.
Yes.
Now you can hear me?
Yes, ma'am.
Okay. I don't know. Something happens to this. It's okay. Yeah. So what was the question? Sorry, I couldn't understand the question.
Okay, ma'am. Few cases, hemoglobin is normal, RBC is normal or it is high, MCV or the indices will be low. What should be the RBC?
In those cases, you must look for alpha thal. Do a molecular test for doing alpha thalassemia traits. They will have low MCV, may not be anemic also.
Okay, ma'am. Then Dr. Nandini had asked similar question. If MCV is low but smear does not show microcytosis, what should be done in that cases?
No. If microcytosis is there, and the HB is normal, and you see the microcytes, please think of molecular test for alpha thal.
Yes, ma'am. Ma'am, Dr. Ramya has asked how to differentiate Hin's bodies from Havel-Jolly bodies on peripheral smear.
Which bodies?
Havel-Jolly bodies and Hin's bodies.
Heinz
Heinz
bodies. Heinz
bodies.
bodies are not seen in peripheral blood. You cannot
Not seen
identify
in-
Heinz bodies in peripheral blood.
Yeah.
Heinz bodies you need to stain with a supravital stain.
You have to make them.
Make them. Prepare. You have to prepare.
You have to prepare
Havel-Jolly
Heinz
bodies are
bodies.
seen in.
Havel-Jolly bodies I showed you.
Yes, ma'am. Ma'am, there is a question. Absolute platelet count is same number as given by the counter. Do we have to count by smear?
What do you mean? If it is adequate, it is adequate, given adequate by the counter, you can go by that count. But if it is not tallying with your smear opinion, first make sure there is no tailing of the or the clumping, EDTA clumping of your sample. So all the clumps have gone to the tail end of the smear. So have a look at your smear for the tailing of the large platelet clumps of EDTA-induced clumping.
Okay, ma'am. Ma'am, in peripheral smear, does platelet clumps mean a normal platelet count?
Sorry?
In the smear, when we are seeing if the platelet clumps are present, does that mean it is a normal platelet count?
Yes.
No. You can. If the clumps are seen, they are there, but how many? 1 or 2 clumps does not mean it's adequate. You can still have lower count on the lower side. A clump doesn't mean that the platelets are normal.
Okay, ma'am. Then how would you determine whether RBC findings, that is sickle cells, schistocytes, or any other type of poikilocytes, are the artifacts versus clinically significant findings?
You have to be sure what you are seeing. If you're seeing a schistocyte, you have to be sure that it is a schistocyte. Now, in case it's a fragmented RBC, what I showed you, the defect of the EDTA-induced fragmentation, well, then you have to make a fresh smear and reassess that patient.
I think we have covered most of the questions, ma'am.
Yeah.
There is a question that even if one NRBC is present and there is a left shift in myeloid series, can we call it as leukoerythroblastic picture?
Yes, of course. Why should it be there? And top of that, polychromasia is the one which actually tells you. We can see leukoerythroblastic. You don't call it leukoerythroblastic, but in all hemolytic anemias, you can see NRBCs and a few band cell metamyelocyte. But the polychromasia is so much that you know you're dealing with a hemolytic anemia. You don't call it leukoerythroblastic then. But a leukoerythroblastic anemia will not have so much polychromasia. And a single NRBC in a normocytic normochromic smear should be very, very significant.
Ma'am, there is follow-up questions on platelet clumps. So they are asking how many clumps, indicates as a normal platelet count?
Oh, clump. Once it is clumped, we will only say adequate or not adequate. We will never give a count. We will never try to give a count. Only whether adequate or not adequate.
And then there is a question, ma'am, how many minimum platelets should be there to call it as a platelet clump?
Even 2 can be together. 3 can be together. If they are sticking to each other, that's a clump. Can be small or large.
Okay, ma'am.
Yeah, I think they mean that how many clumps should be there to call it adequate. I mean, what we had learned or what we have seen is if you see a good it's a very tricky thing. You can say it's adequate. You cannot really do a count. But if you see 1 or 2 counts with 20, 30 platelets sticking together at the tail, you know that the smear is full of platelets. So that's how it is. It should not be just 2 clumps, 2 cells or 3 cells in a clump. It should be a big solid clump of maybe 20, 25 platelets. Yeah, that's adequate. Only then you should say that it is adequate.
Yeah.
Ma'am, there is a question. DLC will be abnormal in aplastic anemia to differentiate from hypersplenism.
Yes. Never.
Yes.
Aplastic anemia will never have a normal differential.
It will always have a neutropenia. There will be neutropenia.
Neutropenia.
Neutrophils will be less, lymphocytes will be more.
For manual platelet count, sir, what should be the multiplier used? The multiplication factor, I guess they're trying to ask.
See, why do arbitrarily on an EDTA smear? Now pay attention. Not on a fresh smear, which will show some clumping. On an EDTA smear in an area where there is just overlapping a stop of the RBCs, and each RBC is lying separate in that area. Each platelet is equal to 10,000. That is how roughly I go about. Please pay attention which area. It is an area.
And in oil immersion.
Under oil immersion. Yes.
Under oil.
Under oil immersion.
Ma'am, there is a question called, can we report aplastic anemia in bone marrow?
No?
Yes, of course.
We report it
Of
as
course, bone marrow
hypoplastic.
mein to karte ho. Yeah.
Okay, ma'am.
What do you mean by that? What else do you need to report aplastic anemia?
So they have asked that usually we will report it as hypoplastic marrow, and the clinician have to exclude other reasons of aplastic anemia.
Yeah, that is true. That is true. The report usually goes out as a hypocellular marrow consistent with aplastic, but rule out. You have to rule out a consistent.
Yes, that is their question. Can we give? The question was, can we directly give it as aplastic?
Yeah.
Yeah, why not? You can give it as aplastic, but you know that all the other conditions also cause aplastic marrow. With that rider, you'll have to give. Always rule out constitutional, rule out PNH, and from your side, rule out an hypoplastic NDS or an AML. Once you have done all that, yes, it's an aplastic anymore.
There is a question on correction factor used for citrate sample, platelet correction factor for citrate sample.
I don't use any corrections.
I mean, no one does.
I don't.
Platelet count with citrate has no meaning. You
I
do it
don't
on the
do it.
EDTA. If there's a discrepancy, do a manual count and report off. Don't waste your time on citrated sample and all that.
Exactly. Very true.
I think as of now we are done, sir.
Okay. Any questions?
Presenters, any questions?
I'm sorry my camera is not working, but you don't have to see me. You've heard me enough. That should be good enough. Yeah. Something has happened too. I don't know. Suddenly it has gone off.
Yeah, thank you, Dr. Uma. It was an excellent presentation.
Thank you, Dr. Basu, sir.
Trifle long, but it was really, really nice. I think the students would have benefited.